Assalamu alaikum and good day. Today we are going to look into the pathology of the ovary. Most common lesions in the ovary are cysts and tumors, and they can be derived from either the epithelium, the germ cells, or the sex cord stromal cells. Primary inflammations of the ovary are uncommon, and most common lesions in the ovary again are tumors, and most common lesions in the fallopian tubes are inflammatory. You can compare this to the epididymis and testis. Again, to recap, the main cells in the ovary are the surface epithelium, the stroma, the germ cells, and the sex cord. All these cells can give rise to tumors. Inflammation of the fallopian tubes are called salpingitis, and most of these salpingitis are caused by gonococcus and chlamydia infection. The first lesion we're going to look at is polycystic ovarian syndrome, which is a common disease occurring in 6 to 25% of reproductive age women. It is a presence of incompletely developed ovarian follicles in the ovaries caused by anovulation and an increase in androgens causing hirsutism. The signs and symptoms begin around menarche and is associated with increased incidence of obesity, insulin resistance, and acanthosis nigricans. Normally, in the follicular phase, LH acts primarily on the theca cells of the ovary, and this will increase androgen precursors. On the other hand, FSH acts on the granulosa cell, and this in turn converts the androgen into estrogen. Both of these will assist in follicular development, and the estrogen will peak and cause ovulation. In polycystic ovarian syndrome, the LH level is very high, but there is less FSH level to the ratio of 3 LH to 1 FSH. The normal ratio is 1 to 1. So there will be an increase in androgen production, but the conversion of androgen to an estrogen is not happening that much. So you have a hyperandrogen state, and this will cause anovulation. The initiating factor is unclear. Clinically, this will manifest as irregular menstrual periods, infertility because of the anovulation, obesity, impaired glucose tolerance or insulin resistance, and signs of hyperandrogen such as hirsutism, acne, or male pattern baldness. The pelvic ultrasound will show polycystic ovaries with more than 12 follicles in at least one ovary. Lab findings in polycystic ovarian syndrome includes the LH-FSH ratio of more than 3, increase in testosterone and androstenedione, decrease in serum sex hormone binding globulin, and normal to decreased FSH level. The treatment includes oral contraceptive pill, metformin, and clomiphene citrate. Next, we look into ovarian torsion, which is a surgical gynecologic emergency. It occurs when the adnexa, which is the tube and the ovary, twist on its blood supply and thus reducing the blood flow, and this leads to necrosis and infarction of the tube and the ovary. It occurs in two clinical settings. In infants and children, the twisted ovary is usually normal. There's no cyst or tumor found. But in the adults, the ovary usually has a cyst or a tumor. It presents as acute abdominal pain that mimics acute appendicitis. And grossly, you can see that in the picture, the ovary is usually enlarged and dark red, and microscopically will look as a hemorrhagic coagulative necrosis. Next, we look at follicular cyst, which is the most common ovarian mass. This is a non-neoplastic cyst, which occurs because of accumulation of fluid in a follicle or in a previously ruptured follicle. Most of these cysts spontaneously regress, but the rupture of the cyst may produce peritonitis with pain. Another non-neoplastic cyst is corpus luteum cyst, which is the most common ovarian mass in pregnancy. This occurs as accumulation of fluid in the corpus luteum during pregnancy, and most of these cysts regress spontaneously. Now we move to the neoplastic ovarian tumors, which are divided into epithelial, germ cell, and sex cord stromal component. 80% of ovarian tumors are benign, and most of the benign tumors occurs in young women between 20 and 45 years old. Borderline tumors occur at slightly older age, and malignant tumors are more common in older women between the ages of 45 and 65 years old. Tumors are more likely benign in women less than 45 years old, and the risk for developing ovarian tumor increases with age. Ovarian cancer is the 7th most common cancer in women in Sarawak and the 2nd most common gynecological cancer after the cervical cancer. The risk factors for ovarian tumors include nulliparity. There is a higher risk for ovarian tumors to occur in unmarried women and women with low parity. Another risk factor is family history of breast cancer and genetic mutation. Genetic mutations such as BRCA1 and BRCA2, HER2 new oncogene, and P53 mutation is a risk factor for surface epithelial tumors. Gonadal dysgenesis such as Turner syndrome is a risk factor for germ cell tumors, and Peutz-Jeghers syndrome is a risk factor for ovarian sex cord tumors. There are reduced risk in epithelial tumors for women on oral contraceptive pills, and the protective role of pregnancies and oral contraceptive pills suggests direct role of ovulation in causing the disease. We revisit BRCA1 and BRCA2 gene, which stands for breast cancer gene, and this is a tumor suppressor gene that regulates DNA repair. Individuals with BRCA1 gene is susceptible to breast cancer, epithelial ovarian cancer, and prostate and colon cancer, whereas BRCA2 gene is predisposed the patients to cancer of the ovary, male breast cancer, melanoma, and pancreatic cancer. Ovarian tumors are classified according to the cell of origin. The first is the surface epithelial derived tumors, which account for 70% of ovarian tumors. They are derived from coelomic epithelium, and the coelomic epithelium is the outermost layer of the gonads. It can be divided into 5 types: serous, mucinous, endometrioid, Brenner, and clear cell. And all of these tumors can be benign, intermediate, or borderline, or malignant. Next one is germ cell tumors. They account for 15% of ovarian tumors, and the cancers are similar to those seen in the testes. It usually manifests in women in late teens and 20s. Most of the germ cell tumors are benign, and they can be divided into teratoma, dysgerminoma, Yolk sac tumor, choriocarcinoma, embryonal carcinoma, or mixed germ cell tumors. Sex cord stromal tumors account for 10% of ovarian tumors, and they are derived from the stromal cells. Some of them produces hormones such as granulosa cell tumors, and most of them are benign. Another classification of ovarian tumors are metastases, and this account for 3% of ovarian tumors. Majority are hematogenous spread, and seeding is a less common type of metastasis. Around 70% of primary ovarian neoplasms arise from the Mullerian epithelium. The classification of these tumors is based on the differentiation of the tumor and the extent of the proliferation of the epithelium. The three major types are serous, mucinous, and endometrioid tumors. And these epithelial proliferations are classified again whether they are benign, borderline, or malignant. The names signify whether they are benign or malignant. If they are benign, they can be cis-adenomas, cis-adenofibromas, or adenofibromas, whereas when they are malignant, they are called cis-adenocarcinomas. The ovarian carcinomas can be categorized into either type 1 or type 2. Type 1 carcinomas are low-grade tumors that arise in association with borderline tumors or endometriosis. These tumors include the low-grade serous tumor, endometrioid tumors, and mucinous tumors. Type 2 tumors are high-grade serous carcinomas that arise from serous intraepithelial carcinomas. Serous tumors are the most common epithelial tumor and the most common malignant ovarian tumors. They resemble the fallopian tube, and classically they are composed of cystic neoplasms lined by tall columnar ciliated epithelium filled with serous fluid. Most of them are benign, but 30% of the tumors are malignant cis-adenocarcinoma, and is usually seen in the elderly. Serous carcinomas occur later in life, and bilateral tumors are common, and most of the serous cis-adenocarcinomas are bilateral. There is a higher risk of malignancy if the tumor is very large, if the tumor has presence of more solid area versus cystic area, and if there is irregular capsule. We see two gross serous tumors. Both of them shows the entire ovary is neoplastic. Picture A has cystic solid areas, and picture B has more solid area, as you can see here. So the microscopic picture shown at below shows benign serous cisadenoma. The cis is lined by a single layer of columnar epithelium. You don't see any complex architecture, cellular pleomorphism, or stromal invasion. This shows borderline serous tumor. You have more complex architecture with nuclear atypia and epithelial stratification seen here. However, there is no stromal invasion. The picture below shows serous cis-adenocarcinoma. It has all the features of borderline serous tumors, such as complex architecture, nuclear atypia, and epithelial stratification, plus it has stromal invasion as seen here. Both borderline and malignant tumors can have peritoneal spread, where the tumor cells are shed into the peritoneal cavity, just seen like in this case. The peritoneal spread reduces the survival rate significantly compared to tumors that are confined to the ovary. Mucinous tumors account for about 20% of all ovarian neoplasms. They occur in the middle adult life, and most of them are benign or borderline tumors. Primary carcinoma of the mucin tumors are uncommon, and mutation of the KRAS proto-oncogene is the most common genetic alteration seen in this tumor. The epithelium resembles cervix epithelium, and they are less frequently bilateral compared to the serous tumors. Grossly, you can see the tumor is usually multiloculated. There are multiple spaces filled with mucoid fluid. And histologically, the tumor is lined by a single layer of mucin secreting cell In this case, it is a benign mucinous tumor. There is no stratification, or the cells are not packed on each other. There's no nuclear atypia, and there's no stromal invasion. Mucinous cis adenocarcinoma shows more complex architecture than the benign tumors. It shows atypical cells and presence of epithelial stratification and stromal invasion. There is a condition that is associated with mucinous tumor called pseudomyxoma peritonei. This condition is also known as jelly belly. This is seen in cases where ovarian tumors has extensive mucinous ascites and peritoneal implants and adhesion. The tumor itself is not harmful, but the mucus has nowhere to go, so it compresses the vital structures such as the colon, the liver, and the kidneys. And this may cause intestinal obstruction and death. This condition can also be caused by non-ovarian tumor such as appendix adenocarcinoma. The third type of epithelial ovarian tumor is endometrioid tumors, and they resemble the endometrium, whether benign or malignant. Some of them are accompanied by carcinoma of the endometrium, and some coexist with endometriosis. Another type of epithelial tumor is clear cell adenocarcinoma, which is characterized by large epithelial cells with abundant clear cytoplasm, hence the name. It resembles the clear cell carcinoma of the endometrium and again associated with endometriosis. The last type of epithelial tumor is Brenner tumor, which is a transitional cell tumor containing neoplastic epithelial cells resembling urothelium, and they are usually benign. They comprise roughly around 10% of ovarian epithelial tumors, and uncommon transitional cell carcinomas can also occur. The typical presentation of the ovarian epithelial tumors are lower abdominal pain, abdominal enlargement caused by fluid and the tumor, gastrointestinal complaints such as bowel obstruction, urinary frequency, pelvic pressure, and torsion. The malignant form may present with weakness, weight loss, cachexia, and ascites. Approximately 60% of the malignant ovarian tumors present with metastasis, and they distinctively seed the serosal surface diffusely. Regional nodes are often involved, and there could be Sister Mary Joseph nodule, which is malignant metastatic umbilical nodule. They can mets to the liver, the lung, or the gastrointestinal tract, and the malignant tumors are usually diagnosed late. The benign lesions are easily resected, but the malignant tumors may require surgery, chemotherapy, and radiotherapy. There is a tumor marker that is associated with the epithelial tumors, and this is a serum level carbohydrate antigen 125 or CA125. It is produced by surface epithelial serous ovarian tumors in 80% of cases and is not released by other epithelial-derived cancers such as mucinous or endometrioid. This is used to monitor relapse or response to treatment. Most ovarian cancers are diagnosed late after the cancers have spread, so this accounts for the poor survival rates of these patients. Compared with cervical cancer or endometrial cancer, only about 20% of women are diagnosed early, where the disease may be curable. The 5-year survival rate for all cases are about 40%, and regular pelvic examinations, ultrasound examinations, blood tests for CA125 have been routinely used for ovarian cancer screening, but none of these tests are specific. There is no definitive way to prevent ovarian cancer for women with ovaries. Now we look at germ cell tumors, which are composed of dysgerminoma, teratoma, yolk sac tumor, embryonal carcinoma, and choriocarcinoma. Germ cell tumors constitute about 20% of all ovarian tumors, and most of these tumors are benign cystic teratoma, They are found in children and young adults, and the features are similar to the germ cell tumors of the testis. Teratoma is a tumor that is composed of tissue similar to tissue in a developing fetus of 8 weeks or more. It is the most common benign germ cell tumor, and it occurs between the age of 20 to 50 years. It is divided into 3. The first one is mature, which is benign. The second one is immature, which is malignant. And the third one is monodermal or highly specialized teratoma. It is usually found in young women during active reproductive years, and the karyotype of all benign ovarian teratoma is 46XX. This picture shows a classical feature of a teratoma. It is a cyst. This is a cyst that has been opened up, and it shows the hair component here, and the cyst is usually filled with sebaceous or whitish fluid-like material. It occurs bilaterally in 5 to 10% of cases. Histologically, teratoma can show presence of endoderm component, ectoderm component, and mesoderm component. If the tumor is composed of only ectodermal differentiation, it is called dermoid cyst. Monodermal teratoma is also called specialized teratoma. There are 3 types that can be found. The struma ovary, which is composed of entirely mature thyroid tissue, just like in the picture. The tumor is going to be composed entirely of follicles containing colloid, and this may cause hyperthyroidism. The second one is ovarian carcinoid, which can produce carcinoid syndrome, producing serotonin. And the third one is strumal carcinoid, which is a combination of struma ovary and ovarian carcinoid. Immature malignant teratoma is a teratoma that has areas of immature component, such as this one. This is an immature component, which is composed of primitive neuroepithelial component. And when this immature component is present, the tumor is considered malignant. Immature teratoma grow rapidly, frequently penetrating the capsule and spreading to other sites. This germinoma is similar to seminoma in the testis. It is the most common malignant germ cell tumor of the ovary. It is extremely radiosensitive and affects the patients in their 20s and 30s. It is associated with gonadal dysgenesis, such as pseudohermaphrodite. Only 1/3 are aggressive, and it has excellent prognosis, similar to the counterpart in the testis. LDH is often elevated. So the histological feature is seen here. It has a large cell with clear cytoplasm and central nucleus separated by the fibrous tissue, and the fibrous tissue is infiltrated by lymphocytes. Another germ cell tumor is yolk sac tumor, also known as endodermal sinus tumor. It is the second most common malignant germ cell tumor and occurs in children and young women. The alpha-fetoprotein level will increase, and many have increase in CA125. It is a very aggressive tumor with rapid growth and usually contains Schiller-Duval bodies, just like in this picture. This is a Schiller-Duval body. And it also contains this eosinophilic pinkish globules rich in alpha-fetoprotein. Choriocarcinoma is a very rare ovarian tumor, which is similar to the testis lesion. It most often coexists in mixed form with other germ cell tumor. It is very aggressive, and it produces HCG. Children may present with precocious puberty. Histologically, it shows the mixture of syncytial trophoblast, which is this multinucleated cell, and the mononucleated cells, which are cytotrophoblasts. Another aggressive tumor is embryonal carcinoma, again similar to the testis lesion. It is the least differentiated form of the germ cell tumor, and it occurs in children and young adults. It may produce alpha-fetoprotein or HCG, and often seen in mixed germ cell tumor. The average age is about 15. So you can see the primitive undifferentiated cells in the picture. The last group of ovarian tumor is derived from the stromal and sex cord component, and they can be from the thecal cells, granulosa cells, Sertoli cells, or Leydig cells, or the fibrous stroma. Some of these cells can secrete hormones such as estrogen and androgen, and they can cause feminizing or masculinizing effect. Granulosa cell tumors are tumors that resemble granulosa cells of the ovarian follicle. They are divided into adult and juvenile granulosa cell tumors, and they are important for two reasons. Because they may produce lots and lots of estrogen, and they may behave like low-grade cancer. Occasionally, they produce androgen, which cause masculinization of the patient, and they also produce tissue and serum inhibin, which is a product of granulosa cell. Granulosa cell tumors can produce three different types of clinical features depending on the age of the patient. In girls who has not reached puberty, the patient may present with precocious pseudopuberty and have secondary sex characteristics at a very early age. In premenopausal women, they cause increasing abdominal girth, menstrual irregularities such as oligomenorrhea, amenorrhea, or menorrhagia. In postmenopausal women, the most common manifestation is abnormal uterine bleeding due to endometrial proliferation because of the excess estrogen. You can have endometrial hyperplasia or endometrial adenocarcinoma in postmenopausal women. All granulosa cell tumors are potentially malignant, and it is difficult to predict their behavior from just looking at the histology. The next group of tumors are the fibroma thecoma tumor, which are derived from the ovarian stroma that are composed of fibroblasts or plump spindle cells with lipid droplets that are called thecomas. These account for about 4% of all ovarian tumors, and they are usually solid tumor, as you can see in this picture. And grossly, they are usually solid tumor with gray hard surface, and histologically you can see spindle cells. Fibroma is associated with two syndromes: Meigs syndrome, which is composed of fibroma, ascites, and right-sided hydrothorax, just like in the picture. It is also associated with basal cell nevus syndrome, which is composed of basal cell carcinoma with numerous abnormalities of the bone, nervous system, the eyes, and the reproductive system, inclusive of fibroma. The last tumor type is Sertoli-Leydig cell tumors, which is similar to the lesion in the testis. These tumors produce androgen that can cause defeminization of the patient, such as breast atrophy, amenorrhea, and sterility, or masculinization of the women, which causes hirsutism, male hair distribution, and voice change. We have covered the non-neoplastic and neoplastic tumors of the ovary, and we have seen the different categories of the primary tumors of the ovary, composed of the epithelial, germ cell, and stromal sex cord tumors. Thank you.